10th with the topic of Journal of Gynecologic Oncology or JGO session with the chair of the session, Dr. Jae Won Kim from South Korea, also with the co-chair, Dr. Nam Kyung Kim from South Korea. Please, for the chair and co-chair, the time is yours.
Yeah, thank you for the introduction and welcome to the JGO session. I'm happy to chair this session with my dear colleague, Dr. Nam Kyung Kim. We have 6 talks, and first 3 talks, Dr. Nam Kyung Kim will moderate. Okay, please.
Hi, my name is Nam Kyung Kim. I'm a second-year fellow at Seoul National University Bundang Hospital. It's my honor to attend the first Honors Meet 2022 as a co-chair with Dr. Jae-won Kim and to join the collaboration session of between JGO and INASCO. Let's start the JGO session. This session includes 6 topics. The former 3 topics are about JGO and the medical lighting, and the latter 3 topics are about INASCO and strengths of Indonesian research data. And we have 2 times of discussion time after former 3 topics and latter 3 topics. The first speaker is Dr. Dong-hoon Seo. He is chief editor of JGO, and you can see detailed CV on the screen. Please, Dr. Seo.
Okay. Thank you for your introduction. Now, let me start my presentation today. The title is all about JGO for you. I'm a current editor-in-chief of JGO. This is the front page of our JGO homepage, ejgo.org. I welcome all of you to this homepage and frequent visit. Thank you. And this is the general information. JGO is open access, peer-reviewed, and SCCIE indexed journal, and we publish every issue bi-monthly, every other month. And JGO is an official journal of Asian Society of Gynecology Oncology and also Korean and Japanese Society of Gynecology Oncology here. And now we don't have any printed version of the journal. We only publish electronically. And we have 3 major societies of gynecology oncology currently in the globe. The first one is ASCO, of course, hopefully. It is based on Asia. And the second and third one is from America and Europe. It is SGO and IGS and ESGO. And those societies have its own journal like this. ASCO, JGO, and SGO, Gynecology Oncology, and ESGO, IGS has Europe International Journal of Gynecological Cancer. So ASCO is the late starter among these 3 societies, but hopefully I will continue to grow faster and faster and beat these two other societies sooner. And these are impact factors, trends. And as you can see here, luckily, we are continuous growing. And the latest impact factor of last year is 4.756. And JGO ranks the first quartile in the category of OBGYN journal, and the second quartile in the oncology journal. And this is the current editor board status. We are all 81 in total, and I'm an editor-chief on your left upper, and we have 21 principal editors from 9 countries. As you can see on the right side, we have non-Asian principal editors too, from Germany, Italy, and also America and Canada. So that means we are seeking, our goal is to become a true international journal, not only based on the Asia. And among the 21 principal editors, 15 is from Asia, and 3 Europe, and the other 3 is from America. This is the editorial advisors. In total, we have 42, and among them, we have only one editorial advisor. I am now seeing him over there, Dr. Haryono. I hope more and more is from Indonesia. And this is a group photo. Unfortunately, we have online editorial board meeting. Usually annually or semi-annually, we meet in person or together, the editorial board, and discuss the current situation and future plan. But yeah, we all know the COVID situation for the last 3 years, and we hold the editorial board meeting online. And this is the JGO editors. The size of circle, the purple circle indicates how big is the volume of the country. So yeah, I'm sorry, the Indonesia, the circle size is so small. You can see here. So yeah, I'd love to have more from Indonesia in the future. And this is another part of the journal members is active reviewers. It is very essential to maintain the quality of the journal, because the peer review quality, the journal depends on the peer review quality. So to avoid the burnout and tiredness of the reviewers, we need quite a big pool of the reviewers. Not inactive, but active reviewers are needed. So the table, the number indicates the active number of the reviewers. Currently, we invite them frequently. Indonesia, we have total 3. So again, I hope to have more from Indonesia. Oh, sorry. To acknowledge the reviewers, we have two common ways to do that. One is the Best Review Award, and the other is reviewer recognition. Yeah, yearly, we publish reviewer recognition, as you can see on the right side of the slide. And as you can see here on your left side, we have three categories of Best Reviewer Award. One is the ASCO JGO Reviewer, and the other two is KSGO or JSGO Best Reviewer. We also provide them big prize money. So please welcome aboard to the JGO Reviewer. And also, I recommend the VIP person in ASCO to recommend your persons to me as a good reviewer. And they, of course, can be a good candidates of best reviewer in the near future. And for example, this is a kind of random volunteer email directly to me all over the world. So this is one person who apply being a peer reviewer. So he sent to me an email with a CV, and sometimes I got an email, this kind of good reviewer. So it's so valuable to me. And this is a submission by country of this year. China is 1/3, almost 1/3. And second, Japan, and Korea, and Italy, and United States. And yeah, the Indonesia is here, the 1%. Yeah, please give more submission, more and more, hopefully. And you can submit your manuscript always via this in electronic submission homepage. Oh my. Yeah, and this is the acceptance rate. One of the criteria we judge a journal is good or not is a lower acceptance rate. Maybe it is not a good for the submitter, because every authors hope their submission would be accepted. But for journal, the keeping the lower acceptance rate is a good point. So we try to maintain the acceptance rate less than 20. So now it is quite good. And the online usage is like here. And the previous JGO international activity, among them, JGO session, like this, from 2016, we visited domestic societies and hold a JGO session. China, Thailand, and Taiwan. And lastly, just prior to the COVID situation, we visited Wuhan, the origin site of the COVID, just 3 months ago. And I'm so happy and glad to being invited. And thank you, all of you, Dr. Brahmana and Dr. Angi, to invite us and hold a JGO session here. And also, we have a JGO workshop program. It is kind of a training program for beginner of the writing. So we have a half-day program, how to write a good manuscript or how to start the good research for the young doctor. And this year, we have a first JGO session outside of the Korea. It is held in Japan during the 64th Annual Congress of Japanese Society of Gynecology Oncology. It is held in Gurume, Japan. So unfortunately, I couldn't make it because of the COVID situation. But I was there online, and it was quite good. And hopefully, sometimes, or in ASCO 2024, hopefully, I would like to hold the kind of JGO session there. And we are trying to enhance our visuality in JGO article. One of that is graphical abstract. We just started this policy, so we will choose one or two good articles for this graphical abstract candidates. And this is the example. This is the template for authors. And the second one is, at the first slide, you already saw that homepage renewal before and after. I hope all of you prefer the after version. Yeah. And we started Ask a Webinar series. The paper is not always easy to read the whole contents in a short time. So nowadays, many good journals start the webinar or podcast or even animation. So we started the webinar, the ASCO, also under the name of ASCO, our official society. And I'm so happy to have this collaboration meeting yesterday, in the afternoon. This is the hot group photo. I just got it from, the Angie person. I forgot her name. And we are planning to start the editorial fellowship program to raise awareness of young gynecology oncologists as early possible. Comprehensively and systemically, I hope it'll be training for helping grow as an independent quality editor. And this is Korean Society of Gynecology Oncology Annual Congress next year, but the homepage, a call for abstract submission is now open. So we welcome any abstract from outside of the Korea international abstract. So please volunteer to submit abstract as more as you can. And hopefully, I welcome, actually, it must be from Professor Jaewon, Professor and President of the ASCO. Now we are starting the annual meeting instead of the biannual meeting. So it'll be a good start of the annual meeting. And hopefully it is the first meeting of the ASCO in Bali, 2024. Terima kasih. As an editor chief, welcome aboard the JGO.
Thank you, Dr. Sa. We will have discussion time after each presentation because it takes time too long or presentation. So you forget questions or comments. Do you have any questions from the floor or online about AGO or ASGO? Yes, Dr. Brahmana, please.
Thank you very much, Prof. Su. Thanks for the moderator. And then thank you very much for letting us joining and then having this kind of great session. And then in ASCO, actually right now, we don't have any official journal yet, but we would like to have one. And then perhaps if possible, is it possible? It's just a question. Just we send some people from us and then just to learn how to manage the journal as good as GGO. That's my question. Is it possible? Yeah, thank you very much.
Of course, why not? Why not? The sooner is better.
Thank you very much. Appreciate it.
Thank you.
Thank you very much. I'm actually one of the reviewer, if I'm not mistaken. Not really active. I'm not really think that I'm active, but I wonder if there is some kind of standardization of being a reviewer, or is there any kind of fellowship that we can follow that you can do the review correctly or in the GGO meeting way? I mean, you know, the IG International Journal of Gynecologic Oncology, they usually have like 1 year, or I think it's a half year fellowship, and all we can do it in a online setting. You don't have to, but but they have to meet in the IGCS meeting, if I'm not mistaken. So they have a 1 year meeting in the IGCS meeting. So if you have that kind of fellowship or that kind of arrangement, so we can do the review more appropriately. Thank you.
I'm so impressed. You're a volunteer. And yeah, as I presented already in my slide, we are planning on the start of the fellowship program. And is a kind of training for good editor and reviewer. And on our JGO homepage, you can find the guidance file for reviewers, also editors. So if you want to find out some guidance, you can refer to that material for now, but please let me know your identification. I contact you when I start my first program of fellowship. Yeah, and from now on, ASCO will start the yearly ASCO meeting, and that means we, JGO, can hold in conjunction with that kind of annual meeting, I mean the JGO fellowship program. So it will be better to start that.
Dr. So, as Dr. So said, it is better to make a session for the new reviewers and new editors one-on-one course during the annual ASCO meeting. So currently we don't have that, right?
Yeah, currently not.
Yeah, so we need to set up the educational course.
Thank you for good presentations. If you want to have a course, I propose to have a hybrid course also, have an online course for a reviewer and for an editor, perhaps. I think it's more accommodative for all of us that could not come. And one more question. I think this is a very general question about how do you, as a Korean that have no that do not have English as a mother of language, could have a very good flow of English. I mean, do you use also the kind of website like that offer us English proofreading or something, or what do you usually do for the English? Because I think uh, I have a very big concern about our English is not really good, especially in written English. Yeah. Thank you.
Yeah, the first question, of course, yeah, we learn a lot from the COVID situation. So nowadays, we always prefer online the communication. So of course, we will have online fellowship programs, and also both reviewers and editors. And the second question, unfortunately, JGO doesn't provide any free English proofreading services for any authors. But yeah, English quality is a very critical and important to what is it, easy readability. So now we can provide the what is it professional company, yeah, English editing company, but it costs money. Yeah, so
Professor.
yeah, sometimes it is a what is it? The reason of the immediate rejection. Yeah.
Professor, I have one question. Is there in GGO have a policy to increasing of research in a low middle country like in Indonesia? Maybe GGO have make the program to collaboration research with low middle income like in Indonesia to collaboration research, and then you can increasing of climate of research in our country. Policy to increasing of product research from low middle income country.
Yes.
Because as you know that Indonesia only 1% and Japan and so on is very.
Yeah, it is a kind of, I cannot say it's a problem, but we have to solve. It is a kind of a homework. Yeah, it is not easy to solve. But, you know, in the Asian region, there are so many low or middle income countries, but I think we have to go together. Yeah, so we have to elaborate some policy, but currently we have no specific policy only for them. So yeah, we have to brainstorming the nice policy.
Yeah, because in my country, especially in Indonesia, is so many cases, but not yet explore about our patient, our cases in Indonesia. Thank you.
Yeah, you are hiding jackpot. So sooner, I hope, it is come to the world.
Sorry for interrupting this discussion. We have no time. So, time. Next speaker is Dr. Seung-hyuk Sim. He will tell us about how to write a valuable paper. He is editor of JGO, and you can see the detailed CV on the screen. Please, Dr. Shim.
Thank you for introduction. It is a great honor to present here, titled "How to Write a Valuable Paper." Today talk is mainly focused on the general principles based on my experience working as a JGO editor job. First of all, today's topic outlined two topics. The one is what to do before you start writing a paper, and second one is how to write a quality paper. Before you start writing a medical paper, you should check these several list, the 8 items. The first one is, have you done something new and interesting? And have you checked the latest result in the relevant field? And have the findings been verified by appropriate analysis, such as the statistical method? And are the method and measurement valid and reliable? And you can describe the scope and limitations of the method. And also, your findings tells a nice story, and work is directly related to a current hot topic. And have you provided the solutions to any difficult problems that introduced by your manuscript? So if all answers above the items are yes, then you can start preparing your manuscript. And second step is then think of your goal and which who is your audience for your manuscript and which journal is appropriate for your paper. If you want to reach a specialist, such as multidisciplinary researchers or general audience, you will need to adjust information and writing styles accordingly to considering the potential audience. Each journal, even in similar subject, such as the clinical journal or the basic research journal, has each readers with a different background, and each journal has its own style. So read other articles recently published to get an idea of what is accepted by a website. And the readership should be worldwide or local. You should consider that. To select the appropriate journal, you should consider the following items. The first one is the aims and scope of the targeted journal. You can check these ones by the browsing website and the recent articles published by the relevant journal. And you can also consider the type of articles, such as the review or the case report or the original articles or the editorial. And you can also consider leadership, as mentioned previously, and also search current hot topics to gain more possibility to be published. And also, you can ask your colleague for advice, and then your colleagues can answer that. This is an important warning feature that do not gamble by scattering your manuscript to many journals. That means you should submit only one at a time. So international ethics standard like COP guideline prohibit multiple simultaneous submissions, and editors finally to find out as please do not do multiple simultaneously submission. And also, the manuscript formatting is very important. So you can see the guide for authors. You can see the general guideline for each journal by the author's guidelines provided by the journal website. And please ensure that you use the correct layout and the section length that stick to word limit for the abstracts or the total manuscript. And also, you should use correct nomenclature, abbreviation, and spelling, and reference format, and number and type of figures and tables that are permitted per each article. And you should also use the appropriate statistics. Remember that consulting the guide for authors will save your time and the editor's time. So all editors hate wasting time on poorly prepared manuscript. So if you do not prepare the properly managed manuscript, it is a sign of disrespect. So editors usually consider immediate reject. For the JJoji, you can find the specific journal for guide for authors. Visit the following the website, and you can see those instructions. And the second topic is how to write a valuable paper. So before preparing the manuscript, two questions for you exist. The first one is, what is the IMRAD, Introduction, Method, Result, and Discussion? And which part should you start with regarding the IMRAD writing? Usually, the article structures, including the following authors: the title, authors, abstracts, keyword, and the main manuscript include main text, consist of the introduction, method, result, and discussion, and acknowledgement, reference, and supplementary materials. So the above four items, the title to keywords, need to be accurate and informative for effective indexing and searching for initial step. And the manuscript each has its distinct function as the IMRAD section. Although the manuscript appears the IMRAD section order, but to clearly convey the meaning of the manuscript and to prepare the manuscript more logically, it is better to write in this order. The first, the write method section, and followed by result, discussion, and conclusion section, and introduction last, and finally, you can write abstract and title at the end. The first, for the method sections, should be the bulk of the paper, and it must provide sufficient information so that a knowledgeable reader can reproduce the experiment, because the scientific articles should be reproducible by other researchers. The method section can be generally divided into several specific parts. Define the population and the method of sampling that were used in your manuscript or research, and describe the instrumentation such as surgical device or the chemicals or the medication. Describe the procedures and if relevant to the time frame, like OP procedure or such like that. And describe the analysis plan. It is very important to show the result. Describe any approaches to ensure validity and reliability in detail. State any assumption, and also you should describe the scope and the limitation of the methodology. Of course, these items can be written in the discussion section. Tips for writing the good method. Method should be detailed, but not any previously published procedures. those can be noted or described in the reference or supplementary materials section. And you should identify the equipment and materials used. A source of the materials or equipment can be used if there is the chance for variability of quality of these items. And next is a result section. So the good writing for result section, it is better to use figures and tables to summarize data and to show the result of statistical analysis and to confirm the method is reliable and justify the choice of the method. And it should be avoided it should be avoided to duplicate data among tables, figures, and text. And it is also avoided to use graphics to illustrate data, but can easily be summarized with text. Regarding graphics, the figures and tables are the most effective way to present the result. However, captions should be able to stand alone such that the figures and tables are understandable without the need to read the entire manuscript. Captions should not contain extensive experimental details that can be found in the method section. The data presented should be easy to interpret. The color should only be used when necessary. This is one example. You can see both the figure and the table. Below the table, above the figure and table show the same information, but the table is more direct and clear. So in this case, you can, it is better to choose to use the table rather than a figure. This is another example of the use of the figure. This figure is poor to be interpreted because the region is poorly defined, graph contains too much data, and no trend lines, so readers cannot understand easily. So this is a better form. The region is well defined, but there is still too much data in the graphic, in the one figure, and no trend lines, so it is still too difficult to understand. And this is the latest version. There are two figures, so now the region is clear and data is better organized. Trend lines are present. Okay. And regarding statistics, we should indicate the statistical test used with all relevant parameters, the mean or the standard deviation, and also should give numerator and denominators with percentages, not only simply show the percentages. And they also should use means, use medians and interpercentile ranges to report the skewed data, or use means and standard deviation to report the normally distributed data. And also report the p-value, if possible, to be presented with in detail after decimal rather than the roughly expression. And also the word significant should only be used to describe statistically significant differences. And the discussion section, this is the most important section of the article. It is where you get the chance to sell your data. A huge number of manuscripts are rejected because the discussion is weak. So, we should describe that what your result means and were the method successful and how did the findings relate to those of the other studies and were there limitations of the studies we should describe. There are several tips for the discussions. The first, make the discussion correspond to the result. Do not reiterate the result. And do not making the grand statement that are not supported by the method or your own result data. Example, this novel treatment will massively reduce the prevalence of cervical cancer in the worldwide. There are 3 grand statements the novel massively and worldwide. But if this expression should be used if the data that support this. If not, you should not use this expression. And third, do not introducing of the new terms that not mentioned previously in your paper. Say, you should introduce the term only after the term is already presented in method section or result section, not the newly presented in discussion section. Avoid unspecific expressions such as higher temperature at a lower rate. Please provide the quantitative descriptions. And speculations on possible interpretations are allowed, but these should be rooted in fact or the relevant reference. Please provide the relevant reference. And compare the published result with your own, but do not ignore work in disagreement with yours. If there exists the disagreement of yours, confront it and persuade the readers with the relevant logics. In conclusion, you should describe how your work advanced this field and indicate the application of your work, and also suggest the future researchers that build on your work and point out research is already underway as well. So tips for conclusions are do not downplay negative result and do not make a statement based on personal opinion without scientific report, and do not repeat other section, and do not overemphasize the impact of your study, for example. An introduction is used to provide context for your manuscript and convince reader why your work would be useful. So clearly address the following items. You should describe what is the problem you are ultimately trying to solve, and are there any solution, and what is the best solution, and what is the current solution's limitation, and what is your work trying to achieve. And finally, outline what was done and achieved in the final paragraph. So tips for introduction include: be brief, usually 1-2 paragraphs is appropriate. Long introduction put readers off. And second, cite a couple of original and important work, including a recent review article. However, editors do not like too many citations to reference irrelevant to the work. So do not describe history. And do not ignore contradictory studies or work by competitors. And do not mix introduction with result, discussion, and conclusion. And also provide a perspective that is consistent with the journal that you are submitting to. At the end, you can write in the abstract with title. The abstract, the quality of will strongly influence the editor's decision. So a good abstract is precise and honest and can stand alone, is brief and specific, and uses no technical jargon, and minimize the use of abbreviation and cite no reference. So use the abstract to sell your article. For title, a good title should contain the fewest possible words that adequately describe the content of a paper. So to convey main findings of research and be specific, concise, complete, and attract readers. And do not use unnecessary jargon of abbreviations and ambiguous terms, unnecessary details, and do not focus on the part of the content only. This is the badly prepared title example, preliminary observations on the effect of tisotumab in patients with cervical cancer. So title is so long, so remove all redundancy, the word, the observation, nature. So it's changeable to effect of tisotumab on patient with cervical cancer. It's more the appropriate title. And second example is the title is the action of antibiotics on the bacteria. But this title is not long, but it's not specific. The title should be specific, and when you design the title, we think that how will I search for this piece of information using the website or the PubMed. So title should be specific. It can be changeable to inhibition of growth of Mycobacterium tuberculosis by streptomycin is most specific and more appropriate title. And supplementary materials include extensive statistical analysis or extensive mathematical analysis, additional data, and video. And it will be available online when manuscript is published. So in summary, publishers do want quality. So we wanted originality, significant advance in field, appropriate method, case studies and conclusion, and readability, studies that meet ethical standards. And publishers do not want duplication of manuscript and do not want report of non-specific interest, work of out of data, and inappropriate or incomplete method or conclusion, and studies with insufficient data. So, to make the manuscript more valuable, first we look back and think it over before you start writing a paper regarding the items as mentioned before, and write manuscript in a proper way with IMRAD section, introduction, method, result, and discussion with good language, and watch the details that are provided by Guide for Authors in the journal website. And also, you should check your paper again when finished the manuscript preparation, and revise the paper accordingly and accept rejection. And you should restart based on this revision and rejection comment. And also, you should behave in an ethical way for preparation of manuscript. Thank you for attention.
Thank you, Dr. Shim. Your lecture is very well summarized lecture and very helpful for us in writing valuable paper. Because of time limit, next discussion time will be after Dr. Park's presentation. Dr. Jung-Yeol Park is Secretary General of ASGO and editor of JGO. Please, Dr. Park.
Yeah, thank you for the kind introduction. Good afternoon, everyone. Slide is not appearing. Today, I will talk about how to prepare randomized controlled trial. Yeah. Why randomized controlled trial? It is because of its high level of evidence. The level of evidence differs according to the study design, and evidence from randomized controlled trial is considered to be at the top of the evidence pyramid, as shown here. And the biggest reason is that there is no bias, or bias is minimized in randomized controlled trial. So it is recommended that clinical practice decisions are based on evidence emanating from well-conducted randomized controlled trials when available. Randomized controlled trial is a clinical trial with two design features. First, it is comparative. It compares the experience of a group of patients on the new treatment with a control group of similar patients receiving standard treatment or no treatment. Second, a randomized controlled trial involves randomization. This assumes patients are assigned to new or standard treatment randomly. The randomized controlled trial is the most rigorous and robust research method of determining whether a cause-effective relation exists between an intervention and an outcome. High-quality evidence can be generated by performing a randomized controlled trial when evaluating the effectiveness and safety of an intervention. The biggest difference between the randomized controlled trial and the other observational study design is that all factors that may impact the outcome equally distributed among study groups in randomized controlled trial. Evidence based on observational data is prone to bias. Bias makes the estimate of the effect of a treatment or intervention deviate from its true value. If two or more groups are being compared in an observational study, there are often systematic differences between the groups so that the outcome of the groups may be different because of this difference rather than actual exposure or intervention. This is known as confounding factors. The only way to eliminate this difference is to allocate each individual to one or other intervention at random. Only randomized controlled trial of a sufficient population size can adequately control for known and unknown confounding variables to minimize bias. There is no substantive differences between groups except study intervention in randomized controlled trial. The first step in the design of a randomized controlled trial is to have a clinically relevant study question. The research subject with the highest impact is the case where there is limited information about the current treatment method or shows various results in previous researches. It is best to drive these research topics based on systematic review. Then, it is necessary to confirm that the question has not already been answered by an appropriately powered randomized controlled trial by other researchers. This requires a systematic literature review. A hypothesis has to be formed for a research question to be answered using a randomized controlled trial. The hypothesis has to be precise. The key components of a sound research question should include PICO, P-I-C-O, population of interest, intervention to be studied, comparator intervention, outcomes to be evaluated. Investigators needed to convert this into an answerable and specific question. The research question also needs to be ethically appropriate to be answered in RCT setting. Investigators cannot subject participants to any rude risk or harm. For clinical trials, it can be argued that it is unethical to expose participants to any risk or burden if the research lacks social values. The randomized controlled trial may not be feasible for a rare outcome event and therefore huge sample size needed, more than 100,000. The randomized controlled trial may not be feasible for rare disease and therefore takes too long to recruit enough patients, or outcome event requires prolonged observation, longer than 10 years. Once a research question is generated, the next step in the conduct of an RCT will be to clearly define the target population inclusion and exclusion criteria, and the process of randomization, allocation, blinding of intervention, treatment and control treatment delivery, outcome assessment, definition of outcomes, sample size calculation, ethical requirements, and the consent process, and finally, data management. These topics should be written as a well-defined protocol, and the protocol should be reviewed and approved by an independent ethics committee before starting the trial. For clinical trials, it is now obligatory that protocols should be registered with a publicly available trial registry before recruiting any participants to the trial. I will highlight the key components of design of a randomized controlled trial. First, randomization. Each of the eligible participants should have an equal chance to be allocated the intervention or not. Generation of a random sequence should be done by some independent personnel, usually a statistician, who is not going to be involved in the conduct of the RCD. The access to this sequence should be restricted to only a few individuals who absolutely need to have the access, like a pharmacist who will preparing the medications, and not the investigators or personnel involved in ascertaining outcome. The sequence should be opened by this individual only on a case-by-case basis, and the specified sequence should be followed. One of the key components of RCT is allocation concealment. This means that neither frontline care providers, investigators, or participants are aware of whether the next eligible participant will receiving treatment or control intervention. This should be masked until the time when participants are ready to receive intervention. This is very important in situation where blinding of intervention is not possible. Blinding of intervention is not possible. Next is blinding. Unconsciousness information bias may be introduced if the investigators or participants are aware of who is getting the intervention or who is not. The procedure of blinding the participants or both in the investigator and participants helps to eliminate this unconscious information bias. Whenever possible, blinding should be used in RCT. However, it is not always possible to blind either the participants or investigators due to the nature of the RCT, especially in surgical trial. If there is no randomization or blinding, treatment effect may be overestimated, as shown here. This figure shows its effect very well. Next is the patient population. The patient population needs to be clearly defined. If inclusion criteria is broad and exclude only few patients from the study, the results are more generalizable, but eligibility criteria is restricted and exclude many patients from the study, the results are less generalizable. It is better to screen consecutive patients with a condition of interest, because skipping patients may introduce bias, and it is good to record the screening log. For patients who were screened but not enrolled, it is important to record brief characteristics and reasons not enrolled. Next is a study intervention. The intervention requires a specific speculation as to how much, how frequently, what dose, what time, and what route would be used for treatment. The new intervention should have the potential for a meaningful medical advance capable of producing a benefit that is strong enough to be detected with a moderate size clinical trial. For comparator, it needs to be clearly outlined whether this intervention is compared with a placebo or no treatment or any other currently used measures. However, because of the ethical principle of equipoise, comparator in randomized controlled trial should be standard therapy arm. If any of the outcome measures of randomized controlled trial are subjective, then it is important that the trial be designed as a double-blind placebo-controlled trial. Despite there is a standard therapy, the use of a placebo may be unethical. Therefore, there must be a justifiable reason for using placebo. Next is endpoint. Selection of the primary endpoint is a key design element of RCT. This is the outcome measure used to make the decision on the overall result of the study and serve as the basis to determine the number of patients needed for the study. Each clinical trial should have only one primary endpoint, which should be defined before initiating the study. Regulatory authorities like FDA and EMA and most journals usually require a single primary endpoint. Use of secondary endpoints is common in high-quality RCTs. Secondary endpoints are necessary because a number of clinical events exist during RCT. When it is difficult to actually see the primary endpoint, there are cases in which a surrogate primary endpoint is set and research is conducted. Next is the sample size calculation. Adequate sample size and the power is a very important component of randomized controlled trial. For that, the conclusions can be applied to the broader population with ample confidence. The requested sample size to test the hypothesis is governed by the effect size. Effect size is a difference in the effect of intervention versus placebo. Effect size is usually derived from previous studies or previous trials or by consensus opinion if there is no previous studies. Researchers need to know the baseline estimate of outcome rate in the placebo and control arm, and it is also important to have an expected estimate as to what percentage of patients are expected to benefit from the intervention. Expert statistical help should be sought with these two information to calculate the sample size. And once a sample size has been established, it is necessary to check whether this number is realistically possible. Next is the power of the study. There is a three concept, type 1 error, power, and type 2 error. The chance that a difference in effect will be found even if there is no real difference is type 1 error. Type 1 error is usually fixed at 0.05 due to convention. This is the same that p-value less than 0.05. However, it is not necessary to fix this at 0.05 and the other levels of significance, 0.01 or 0.005, may be chosen. In contrary, it is also possible that a significant difference may not be observed even if there is present. The chance that the study will be able to demonstrate a significant difference if it is present is known as the power of the study. By convention, the power of the study is fixed at 0.8 to 0.95 level, 80% to 95%. Inability to demonstrate a significant difference, even when difference does exist, is known as type 2 error. The probability of a type 2 error is conventionally set at 0.2 to 0.05. With these values, it will be easy for a statistician to calculate the sample size. Next is null hypothesis and alternative hypothesis. In a superiority trial, null hypothesis is that the two treatments yield equivalent results. Alternative hypothesis is that the treatments yield different results. If a p-value is less than 0.05, null hypothesis is rejected and the alternative hypothesis is accepted in superiority trial. The study is conducted in an attempt to gather sufficient evidence to show that null hypothesis is incorrect. If a type 1 error is fixed at 0.05, null hypothesis is rejected and the alternative hypothesis is accepted when p-value is less than 0.05. We should determine that how many type 1 and type 2 errors are we willing to accept before rejecting the null hypothesis in calculating sample size. Next one is analysis plan. The data analysis plan must be defined in advance. It should be decided whether to analyze the outcomes in the intention to treat population or in the per protocol population. In intention to treat population, all patients randomized are included in the analysis regardless of receipt of study intervention or follow-up. But in per protocol population, only patients who received sufficient study intervention and followed up sufficiently. The subgroup analysis plan should be also be determined in advance, and the interim analysis plan also should be determined in advance. In interim analysis, the analysis may include a plan for futility analysis based on efficacy and or safety analysis. Next is monitoring and DSMB. Safety of the patients who participate in clinical trial is of paramount importance. For RCT, this safety is achieved by two main mechanisms. One mechanism is the monitoring of each adverse event report. And the second mechanism is Data and Safety Monitoring Board, DSMB. This is an independent committee established to assess at regular intervals the progress of randomized controlled trial regarding enrollment, safety data, data quality, and the critical efficacy endpoints. Now, this is the last one, trial registration. For clinical trials, it is now obligatory that protocols are registered with a publicly available trial registry before recruiting first participants to the trial. Most journals have this as a mandatory requirement for publication, and the journals will not publish the results of ICT unless trial registration details were provided. Retrospective registration of the clinical trial after enrolling the first case not be acceptable for publication. In conclusion, the RCT and the RCT is most rigorous and robust research method for determining whether a cause-effect relation exists between an intervention and an outcome. Therefore, it is important to perform randomized controlled trial to generate evidence and improve the management of patients. However, RCT should be conducted only if it is ethical, feasibility, economically viable, and clinically worthwhile. Thank you for your kind attention.
Thank you, Dr. Park. We will have next discussion time after remaining presentation are finished. So please.
Okay, thank you. And our next speaker is Dr. Lina Agustina. I believe she's online. She's a clinical nutritional specialist, and I heard that she has an experience publishing a paper in the Lancet. So, would you start your talk?
Yes, thank you very much. Okay, salam. Yeah, thank you very much for the opportunity. Assalamualaikum warahmatullahi wabarakatuh. Let me now share the screen. Okay. Yeah. Good afternoon. Maybe good morning to afternoon, everyone. Once again, thank you for inviting me here to speak related to good to conduct the clinical trial in Indonesia. Here, I would like to mention that I came from the Department of Nutrition and Human Nutrition Center, IMRI, Faculty of Medicine, University of Indonesia. So this is the outline of my talk today. If we can cover all, if it's not, that we will prioritize on some important issue. So I would mention that this is one of the information that we put it in our Lancet paper in 2019. It's about the universal health coverage, mentioning that Indonesia is quite heterogeneous and also have a complexity and diversity problem and also opportunities. So there's a unique challenges for health system and universal health coverage. Not only is the fourth largest population in the world, but it's also some growth on the economic development, GDP, the Human Development Index, and urbanization, as well as there's still large disparities from west to east, which actually managed by decentralized local governments. Of course, this will give a large geographical, medical, social practice and culture, belief, and also community participation, which actually very important for a clinical trial. So I would say that based on that and many of the achievement has been done, Indonesia is a model for solving global health problem. Although it still have a triple burden of malnutrition and some problem on neonatal and maternal mortality, therefore centralized one size fits for all health system will not be enabled to address the problem of diversity and complexity, and also reduce health equity and also the burden of health costs. So therefore, really important to do a lot of trials and studies in Indonesia, which actually can give some model for solving global health problem. So clinical research, therefore, is a key solution for many problems, health problems throughout the world, including Asian country and Indonesia. If we look at more specific trial, are much more conducted in westernized society. If you look at trial in Asian countries, here what is the figures? But we see that yeah, there's some trials already conducted in Asia, Southeast Asia. Indonesia are still far from Thailand and even Malaysia. So it's about 400 for clinical study, but the opportunity will be more and more. And we could mention that there would be a potential aspect that we can name it to mention as the reason why clinical trials in Indonesia can be conducted in more and more in the future. So there are 5 different items that might be good to discuss further and put attention on. The first one is that there's a huge, as a variety, complexity and diversity in Indonesian problem and also population. There are also high incidence of infectious and chronic disease. So there's a wide variety of this disease, which actually enable the availability of also the research subject. So this is actually one of the very interesting aspects, especially because Indonesia is tropical country and many tropical diseases are also occurring in this particular population. And the second is that there's a relatively low operational cost compared to Western markets on conducting the trial, and some other supporting environments, such as a more improved regulatory environment, perhaps less strict than the other countries, and also improved laboratory facilities, skill set, talented scientific person and personnel, and also large, as I mentioned before, large scale, enormous potential for recruiting study subjects, so more availability of research subject. So again, so there are the reason for clinical trial in Indonesia. So the implementation of clinical research in Indonesia is also some uh, potential benefit as mentioned before. But then the question will be, how can we be assured that the quality of the trial meets the global standard? And are there clear regulations that control the conduct of clinical trial in Indonesia? And are the local regulation compatible with internationally accepted principles? So, so here a figure is showing the trial in Indonesia, which coming from about five. Uh, 505 records and showing that there's a 402 record intervention study and 103 record observational study based on clinicaltrial.gov and other registry. So, well, this is let's say this number is has increased substantially. Although there's a different trend between the observed number of the multi-regional clinical trials and regional clinical trial. So there's a rapid improving on the MRCTs in 2007, but there's also some decrease due to some regulation on MTA, for example. And there's a trend of regional trial at the other hand, whereas it's increasing, although it's still fluctuated, and there's highest number in 2017. So these are just a summary of the RCT in Indonesia to that particular additional information. Like, for example, there are most phase 3 and 4 in trial in Indonesia than the first one, which involve many provinces and targeted mostly adults, and revealing that the preference of multi-regional clinical study in Indonesia has mainly been for a large number of prospective recruits. So those actually, as I mentioned earlier, where the wide range of population are there, including also the vulnerable groups, infant, children, pregnant women, and elders. So what topics are actually the most studied? So in relation to the non-communicable disease and infectious disease, the cancer are much more studied in multi-regional RCTs, whereas diabetes is much more on regional clinical trials. For infectious disease, tuberculosis is the most studied infectious disease, and malaria is the most studied for regional clinical trials. So on the NCDs, apart from the cancer, diabetes, cardiac disease, hypertension, and also gastrointestinal disease are also the topics are of interest. For cancer are much more related to the non-small cell lung cancer, which will mainly due to the incidence of the smoking rate and mainly sponsored by global pharmaceutical company. While for infectious disease, apart from malaria, tuberculosis, there's also study for vaccines, HIV and dengue. And this is mostly sponsored by the national, local, global sponsor. So, well, there are huge opportunity of RCT in Indonesia. From the previous the explanation seems to be that there's an attractive site for the multi-regional clinical trial, and the vaccine trial will be becoming more and more attractive and may still have better opportunity since the needs are quite urgent. And but there are also some fluctuation due to material transport agreement period of policy. So if we can summarize, there are also challenges in conducting clinical trials in Indonesia. So there's a two aspect. Sometimes although there's a lot of talented personnel that I actually experience as well, but in some aspect, also there's a limited resources for skilled personnel, resources, and of course the funding. And in this interact with the lack of research environment, limited resources of skilled personnel, and competing in demand and also operational barrier. So for the regulation ethical constraint, this lack of local policymakers understanding regulatory challenge and also ethical and regulatory system obstacle. This is a more detailed one. Maybe we can put it as discussion. So in the era of pandemic COVID-19, all these challenges actually are also need to be improved more to have a better partnership on conducting the trial on COVID-19. So therefore, issue requiring attention would be to have that for high quality RCTs. This might be something we need to be seeing as a barrier that might need to be also overcome, like a contract research organization, material transfer agreement, accreditation of ethical committee, the GCP training, and also local insurance company to actually protect the subject as well as the researcher. To emphasize the strength of clinical trial in Indonesia, as mentioned before, but I would like to put some more here, where the availability are actually the opportunity, like hospital and health centers, capable and qualified manpower. We can discuss about it, of course, in somehow regulation related to clinical trial, a strong and high quality pharmaceutical industry, and what is this range. And this is the weakness that might be implementing the challenge that I raised before, such as less standardized ethical committee, although this is raised in 2015 and then now improving a lot, and lack of network in drug development research, low quality of some clinical trial, and some less friendly regulation, lack of insurance company, and small number of research-oriented local pharmaceutical industry. And most of our pharmaceutical company lack spirit to innovation for the research of the trial based on what is being proposed by Professor Rianto Setiabudi. So therefore, we have to bring the opportunity. The global need to develop new drugs in a short period of time, need to develop the vaccine. Large patient population are there and competitiveness of research costs. And there also the opportunity to filling up health problem in Indonesia. So I would like to skip this, and I will like to go the experience that we are having in conducting clinical trial. So especially on nutrition and health in Indonesia. So this is one of clinical trials on probiotics and calcium supplementation that we conducted, screened for 4,000 children and included almost 500 randomly assigned subjects in 2007-2012. And this has been very successful clinical trials with excellent compliance and with the outcomes on the giving the probiotics on L-Kasi and L-Reuteri, improve the incidence of diarrhea, also duration, and also improving the growth of the children 1 to 6 years old. And this then has been published in high impact journal, and with large randomized trial follow up then 10 years later. So we then publish it in the Nature. The findings that we have on the increased resistance to diarrhea, improve reduced diarrhea incidence, reduced stunting, and improved growth, later directed to the depressive and cognitive outcomes improvement as well in the later when they were teenagers after 10 years follow-up. So, and then reduce risk of, especially of female obesity. So then we did a lot of other clinical trials in Human Nutrition Research Center, IMRI, such as this is one of large trial as well. We conducted for 314 mothers for the promotion of maternal gut microbiota and psychosocial stimulation and child cognition. That we follow up from second trimester until 6 months of the baby, but now it's also follow up until 36 months period where we provide the probiotics and CPUFA. where we actually measured the imaging fetal brain development during pregnancy and also some other cognitive development. So then we also conducted a trial, now it's ongoing on the, what we call it, a change project. It's a combined zinc, chromium, vitamin C, and copper supplement for pre-diabetes progression for 670 pre-diabetic adults in Jakarta, which aim to improve and measure mean level of glucose profile. So then the other trials that are also just finalized on the effect of probiotics and vitamin D on intestinal dysbiosis, as well as now a new initiation trial on that remodulation of gut microbiota to the adolescent, involving about 450 up to 500 subjects for 3 different cities. So based on that experience, there's a huge management that we are conducting, like a reduced preparation phase. This is listed here. I do not have to mention all, but it's just to give an impression how we actually conducted the trials on the preparation phase. There's a lot of administrative paperwork that has been done, but also a lot of technical issue that has to be prepared, such as, for example, the logistic aspect, data safety monitoring procedures, all the SOP related to the trial, as well as the CRF. So this is the clinical trial in action to be successful, where a conduct phase and end phase are well managed. So this is just impression what we have done in the conduct of the phase and end phase of the trial. So before I finalize, I would like to come back again to my previous slide. So in our experience, there's a key success story for RCT that need to be maybe can be as a learning point for many scientists who would like to do the trials in Indonesia. The first one that we are aimed to always go for WOW project. WOW project is innovative, large scale, as well as having relevance to solving the public health problem. And the second is about leadership. So leadership trial manager here, I would like to mention that we actually, apart from the problem that sometimes we face on the manpower, we actually involve the senior and young scientists together that dedicated to trial managers. So trial managers really important to our trial design and also funding application. So the other part of the key is that the solid team and a good project organization structure. So we are able to conduct the trial efficiently because of the teamwork together harmoniously, efficiently. Everybody works according to timeline and budget. And of course, the structure organization. The other four key that we experience is that involvement of young scientists, as I mentioned before, including students, doctorate, master, bachelor, postdoc, internship. Those are through the training and opportunities to involve. So essentially, training to them assure their proper conduct, maintaining good quality implementation of the trial with a very strong commitment. So maybe this is the other key is that success of the trial is heavily dependent on the close harmonization of these elements. The principal investigator, sponsor donor, specialty department and lab, optimal resources allocation, research team, research administration, and data management, monitoring, and IT use that we actually use for the trial. So the other two last key success I would like to share is that, sorry, the last three, community participatory. So most of our trial is community-based setting, which mobilize and empower many different key leaders and also community participation. So it is based on individual approach to subject and work together with local government, local authorities, local leaders, cadres, and identify community characteristic, culture, belief, behavior, food pattern, as long as soon as also health condition and social life might be also in addition to that. And the other key is knowing potential impact of research to public health improvement. So this gave a motivation to the research team as well as the research subject. So we give information what is beneficial of the program and how to improve their health, including health foods and healthy lifestyle and so on. And to have a good orchestra between the research and the researcher as well as the environment around the supporting of this trial. Last but not least, we knowing potential impact of research to public research improvement. So here we usually have the previous formative survey first, and then later we do a lot of monitoring and evaluation to have knowing potential impact of research to this public health improvement before and after the study, and even after some years of the study. Hey, so I would stop this now, and by conclusion, there's a number of clinical trial research capacity resource maybe still lacking in Indonesia and developing countries, but can be improved and give a lot of opportunity to do the trial in high quality manners and also in ethical conduct. The greatest challenges that face researchers in developing countries were limited resources, skilled personnel, but this can be overcome with the trained capacity building involving senior and young scientists and other personnel with good training. But funding, regulation, ethical constraint sometimes also hinders and successfully key on clinical research such as trial manager, harmonious, effective team involving stakeholders and young researchers. Last but not least, publication in high quality and impact paper need to be encouraged along with potential policy brief and product development, and we have proven this is possible. Thank you for your attention. Once again, Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Rina Agustina. Thank you for sharing your very great experience and perspectives. But due to time limit, we have to move to the next topic. Thank you. And our next speaker is Dr. Brahmana Askanda, current president of the UNESCO. He will talk us about UNESCO.
Thank you very much, Professor Kim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. I will talk about UNESCO, and then the title actually all about UNESCO, and then I just would like to connect UNESCO with the scientific things. Next. So I'm telling the story about the UNESCO. Actually, it's not founded 2009, but the declaration, I don't know what, but actually established since 2000. So it's been 22 years old right now. And then now the member 129, actually 125, and we're talking about it. And then the headquarters still in Jakarta, perhaps move to Kalimantan next 5 years. Yeah, thank you. Slide. This is the members, 125 gynecologic oncologists, and then 24 doctors still on training to become a gynecologic oncologist. And then we are trying to produce like 50 a year. And then so for the next 5 years, so our organization become larger because a lot of new members joining our organization after they finish the training in gynecologic oncology. And then this is the distribution of our UNESCO members in Indonesia. And then Dr. Rina talking about disparity. Yes, also if you take a look at this one, look at the Jakarta. In Jakarta there are 29 gynecologic oncologists, but look at the Kupang entity, just one gynecologic oncologist, and also in Sulawesi Tengah, one gynecologic oncologist, 29 in Jakarta, and then 15 in East Java. So the distribution is unequal. Yeah, that's why this is also the problem. So why this is the explanation why the scientific thing is not really developed right now, but we have to be developed because right now most of our gynecologic oncologists, they are prioritizing working and then, serving the patient. So in the future we have also really much involved in the scientific writing, scientific publication, and such kind of that things. So we are highlighting with the yellow one, that's the province that still does not have gynecologic oncologists. The province with a lot of population, but still there is no gynecologic oncologist. We still have 10 provinces in Indonesia that does not have even one gynecologic oncologist. Hopefully within 5 years that every province in Indonesia, they have gynecologic oncologist, so it's easier for the patient to be treated, not to be referred to the other area. We take a look at the age distribution. Now, there are 13 young gynecologic oncologists. We consider it young, under 40 years old. So we hope that those 30 gynecologic oncologists is really have a passion in scientific things, writing papers, and also do the publication in reputable journal and something like that. And then also the second largest groups is between 41 and 50 years old. So I think, if we are looking at these figures, we still have hope that in the future time that we can really involve in a larger scale in publication, in scientific, in clinical trial, and something like that. This is the distribution based on the sex, still dominated by men, 84%, and then just small percentage of female gynecologic oncologists. I think in the future will change really very much, about 50 and 50, because more and more female gynecologic becoming our members. This is the center of education right now in Indonesia. So the education is university-based in Indonesia. It means that if you want to be a gynecologic oncologist, you have to apply to the university and then spending 2 years official duration of time of becoming gynecologic oncologist. And then the centers of education right now is just 3 in Indonesia: Jakarta since 2000, Surabaya since 2009, and Bandung since 2010. And then I think several centers now joining to be the center of education for gynecologic oncologists, perhaps Makassar, and also Medan, the area that has enough gynecologic oncologists to be the center of education. Yes, we have a cancer registry, but the data collection is got from several gynecologic oncology center, and then it depends on the compliance of each center to enter the data. Some center is very active entering the data, and then some center is still inactive entering the data. So in the future time, we have to improve our cancer registry. Publication based on the INASCO cancer registry is still our homework. Then in the future time, we hope that several papers can be published in the reputable journal based on our cancer registry. And then cancer registry now is coordinated by Dr. Anggi, and then the system, the IT, and then how to coordinate the coordination, I think we have to discuss and to improve it soon. this is several collaboration that we started now. We started with some joint webinar with international expert. Yeah, several times, almost every 3 months, we have international session. We consider international because the speaker were not just from Indonesia, but also the well-known expert in the world. Yeah, perhaps in the future time, in the couple months, we hope that we can also have a collaborative webinar with ASCO expert. Yeah. Yeah. And now also we are trying to collaborate with our friends, the stakeholder in gynecologic oncology management, like pathology and also radiotherapists. We have already had a meeting several times with the Society of Pathology in Indonesia, and then we are planning to have a meeting with the Society of Radiotherapists in Indonesia, because it's important if we have a discussion with our friends, so we have a same mindset, and then we can work hand in hand in closer, then we can serve our patient better. So we also have a collaboration with IGCS, with IGCS Strategic Alliance, and then Indonesia is listed as the member of IGCS. Yeah. And also, since last year, we have joining IGCS Tumor Board, ECHO Tumor Board, and we are joining the Vietnam Tumor Board actually, and then coordinated by the IGCS, and then in the mid-2022, we are approved as the host. So started from December 2022, Indonesia will be the host for IGCS Tumor Board every third Thursday every month. So every third Thursday every month, we have a IGCS Tumor Board. And then thank you that if Prof. Kim also would like to join our regular tumor board every Thursday. Usually we have that meeting every 7 a.m. in the morning, 7 a.m. in the morning. And then we are still coordinating for the December IGCS Tumor Board. Yeah. And also with ASCO, we have collaboration with ASCO. This is the picture of online meeting, ASCO meeting, last ASCO meeting that held in Beijing. Yeah, that held in Beijing. We are also joining. Thank you very much, Prof. Kim and Prof. Park. And then I read from the GKO paper, one of the GKO paper published in GKO, that the participant from Indonesia is the fourth, listed in the fourth one, with 91 participants in the last ASCO meeting. Yeah. And thank you very much for ASCO that we are appointed as the host for ASCO meeting 2024. And then 2 days ago, we had a discussion, initial planning, and then the date would be, and then the date would be on 29th of November, 30th of November, and then the 1st of December. And then the location will be in Nusa Dua Bali Convention Center. Yeah. Slide. Nggak bisa ini. Ada lagi slide? Oke. Slide berikutnya nggak bisa. Sorry. So we have also had a discussion with Prof. Park. Then we hope that many members of Indonesian Society of Obstetrics and Gynecology can also join in ASCO 2024 in Bali. Yeah. Now this is 2 days ago. Yeah, we had a discussion with Prof. Park, Prof. Kim, Prof. So, and all the Korean delegation team talking about the planning of ASCO meeting 2024 that will be held in Nusa Dua, Bali at the end of 2024, because also we're going to be see Indonesia will going to be see 2024 because there will be election for our president and then also the election for the governor for all over Indonesia and also the head of the major for all over Indonesia. So the scientific plans of UNESCO, I think we have to push our joint publication and improve the cancer registry that will be talked by Dr. Anggi after the next topic. And then also we are planning to have a UNESCO journal. Hopefully that within 3 years or within 4 years, we have our own journal. And then at the beginning, we have to learn from GKO if Professor also welcoming us to learn how the GKO organized the journal. And then we also will try to create our own journal. Yeah. Okay, I think that's just a little bit about our society, and then we hope that the young generation especially is really very much have a passion in scientific writing, publication, at this kind of thing. And then we hope that Indonesia can really involve in the publication. If you take a look at the figure presented by Prof. So, just only 1% submission in the GKO. GKO accept submission, not accepted paper, just 1% from Indonesia, right? So I think we hope that perhaps in the 3 years' time, it could be increased to 5%. Thank you very much. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much for your overview of the UNESCO. Please stay. Dr. Brahmana, please stay on the stage, and thank you for the overview, including history and composition and various activities and future plans. So, do you have any question or comments? So, I have a question about the number of GIN oncologists of your society, 125. So the number is a government policy, or there is any? Yeah.
Okay. So it's really small number if we take a look at how big is our country and then how big is our population with just only 125 gynecologic oncologists. Of course, it's very too little, because actually gynecologic oncology in Indonesia is the youngest organization, I would say that, I don't know. And then to create a new training centers, there is a several requirement also from the government. And for the last 5 years, all the education included the gynecologic oncologic teaching should be based in the university. And then it's make more quite complicated, but we still have hope, because now we have 24 in training right now, and then hopefully that we can produce, I would say that we can produce like 30 to 40 to 50 new gynecologic oncologists per year, hopefully. Yeah, because we realize that that's too small number, 125, and then also still 10 provinces in Indonesia does not have even one gynecologic oncologist. So the story behind that, why it's too small, I don't have any exact answer, but perhaps it's because of the regulation. But luckily the government realized now, and then the government now trying to ease the requirement of the regulation, so they can more and more training center can be created, can be built, and then to teach all the general gynecology to become a gynecologic oncologist. That's perhaps the short answer of your question.
Thank you. And I'm also impressed with your activity with the s10 and IGCS webinar and other industry partners. And as you know, we s10 recently established education committee. So please join s10 webinar also.
Okay, okay. That's why we would like to invite and then regular webinar with ASCO, and then also we have a discussion with Dr. Anggi. Then perhaps every month or started with every 2 months, we have a kind of scientific webinar from the GGO. And like how to write and then how to make a clinical trial. So it's repeated scientific webinar. So I hope that that kind of seminars can induce the passion of scientific writing of our young gynecologic oncologists. So we really very much looking forward for closer cooperation with ASCO. And then once again, thanks for coming to Bali. Yeah.
Thank you. Thank you so much. We'll move to the next topic. Thank you. And our last speaker is Dr. Trisha Dwi. She will talk us about her big data and big ambition.
Thank you, Professor Kim and Dr. Kim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang. Good afternoon, ladies and gentlemen. My name is Trisha Dewi Anggreni. Ya udah. Actually, I have a new title, but it's okay. I think it's still relevant. The Indonesian Society of Gynecology Oncology Cancer Registrations Information Systems. So many of you from the Korean will ask whether Indonesian have the data or not. Actually, we do, but we don't know how to use it. Maybe we can give any advice from you how to use our own data. So this is the outline. It's a background. The cancer is major public health problem worldwide in Indonesia, and Indonesian population is still in 2010. It was a long time ago. So nowadays, I think it's already 275 something, and maybe 200,000 women will suffer from has a chance for suffering from gynecologic cancer. And cancer should be not a viable disease that inaccurate data will cause the poor cancer registration system. So the solutions, if you ask me before the solution, Anggi, how many cervical cancer in your institution? Well, I only be able to say many, but I don't know exactly how many. Actually, we do have our own cancer patients for the cervical cancer. So the UNESCO made the cancer registration information system is a national for 26 national teaching hospital base. So it's a web-based that including 26 university teaching hospital who has gynecology at services. So the background is no accurate data regarding patients with cancer, no accurate data regarding type of cancer and cancer treatment, and more time is needed to search patient data using medical records. We should find with a very lot of books and 30 books maybe in the medical records rooms. No cancer database for research, sharing knowledge, and planning program prevention, screening, treatment related to the cancer. So the solution, we try to make our own cancer registrations from the west to east. Why do we need the cancer registration at that moment? Because for the administrations, of course, for public health interests, for assessing outcome patients care. So to be honest, we never assess every guidelines that we made to our patients for 1 year, 2 year, or 5 years. So we just use the guidelines, but never assess what is the outcome of the patients. And also for the health educations, informing the public, and also for the teaching. Because if my student asks, how many cancer patients do we have, doctor? What was the reason why we still have a cancer patient come in advanced state? I cannot answer. And no, we know because the screening coverage of our patients are very low, so still in 6 and 8%. And also the important thing is for the research, for descriptive epidemiology, and also the last for the evaluation and intervention. Well, even the descriptive epidemiology, we don't have it. So after we make the cancer registration, we want to know whether our cancer registration will fulfill the criteria to be put as a cancer registration. So we're trying to make a small research using the quality assurance research, non-experimental, no data manipulation. We are trying to make a data component quality of our cancer registrations to see the comparability, accuracy, and completeness. And collecting the data, we use by observations in the field and interview of cancer registry supervisor and data inputter. First, as a pilot project start in RSCM Jakarta Universitas Indonesia. And we use templates of quality assurance using Freddie Bray and Max Parkins. The results, the comparability according to WHO guideline, how many criteria should be put in our cancer registrations, and the fidelity according to evaluation, the methods, and the completeness, the recommendation, and what kind of the obstacles that we are going to face. So for comparability, we are trying to see actually what are the data or the criteria that should be put in the cancer registry according to WHO guidelines, ICDO. So it says that 9 main items information should be put in the cancer registration. So we see in our cancer registration, we already have those 9 items except for the sex, because most of our patients are females. So from the name, age, municipality, topography, basics for diagnosis, morphology, incidence, deaths, the date of the death. And for the validity, the accuracy, we are trying to evaluate the methods from 4 criteria: the abstraction and the recording, diagnostic criteria, missing information analysis, internal consistency methods. And the result that for the abstraction and recording, we put the level of privacy in every center. We have every level we have a data entry, supervisor, and administrator. So the data entry has only be able to put the data. He cannot change if they put wrong data. It needs supervisor or administrators to change the data. So every level has their own capability to be in the cancer registrations. And every center we give a different login. So I cannot see what is the data from Surabaya, what are the data from the Bandung, because they have their own login. So if we want to have a collaborations to put together the data, we should make letters, agreement to have the same. If we want to, like I said, Dr. Brahmana, I want to have, let's make research about it, and I need the data about this. There will be regulations to manage that. And the data entry need verification. So we do we have to verify the data for every day, because sometimes they will put in wrong items. And the diagnostic criteria, we use the most valid basic diagnostic of a cancer. We have a pull down menu as well to make it easier to put the item. So stage 1, B1 will be the same every center. So not only item, because if a item sometimes 1B, it could be 1B1, 1B2, and 1B3, and we follow the change of the stagings according to the ICC, NCC, NCS, and the histology, the accuracy of the diagnosis. And the source of data still find difficulty for notification of death certificate, as I already mentioned it before, because I don't know how to validate with the patient's cancer that because of the disease, the cancer, or that because of the accident. And sometimes we are, as a third referral hospital, most of our patients came from different city, different islands, changed the address and changed the mobile phone many times. So for the survival, we find it is very difficult. So that's why that I asked the questions yesterday. Should we wait this to be fixed? Because if we have to wait until it fixed, we are not going to publish anything from our data. Yeah, we know that DCO is less accurate, but if no previous complete data. So error in code application minimized by data verification. As I told you before, that we did the verification for every consultant with the data inputter. And missing information analysis, we have a pull-down menu to minimize the difference. And the internal consistency method, data collected by contracted register for medical record. We find it very difficult because they always change all the time. So that is why sometimes it's very difficult to be consistent. And they start from 8 to 3 p.m., not 15 p.m. Lack of this system, no data manager. We talk already, Dr. Brahmana, nobody want to pay, so we have to pay by ourselves. Yeah, and it has multi-tax in the hospital, and not all hospital has online medical record. Now we start with the medical record, but it's a lot of variance from one hospital to the other hospital, even in Jakarta. So every hospital make their own medical record. So sometimes it is very difficult. Anticipated patient's name, patient family name. We use, sometimes we don't have a patient name, so we use the what is ID card, and also the name of the mother, because father may be changed, but the mother will not be changed. And the completeness, the recommendation that we should have history data method, stability of incidence rate over time, comparisons of the incidence rates in different populations, shape of the age obstacle. We are a large population, and developing cancer screening is still one of the obstacles in our country. Mortality incidence ratio, number of source notifications per case, historical verification of diagnosis, no online medical record, poor medical record storage, no collaboration with the government, so we should make our own, and no coverage of government or private insurance. But nowadays, since 2013, the government made an insurance government for Indonesian's population. I hope that it should be better in the future. So the strengths, like Dr. Rina said, that we are a large population, many cases, many variations come from the Indonesian populations, and we use website-based, easier data collection and national data reporting, avoiding double entry by medical record number, demographic variable that I already mentioned this before, ensuring data security, limited access for unaddressed personals, we use the usernames. And the weakness, no online medical record, limited financial support, no optimal contribution for each institution, no integrated collaborations among hospital, government, and insurance company. Opportunity, research and publication, epidemiology, multi-center research, but we haven't used this at all. And the threat, sustainability, always, if we made something, the sustainability become one of the challenges. Human resources, financial support, website maintenance, so this kind of thing. So this is a summary about the INASGO cancer accuracy actually has a good prospect. Even though we don't have a data, we do have here, but we don't use it in an appropriate way. Even though this cancer registry have a strength and weak point of its implementation, several improvements have been made to update cancer registry toward global changes. However, poor coordination and limited financial support have been anticipated for the sake of this cancer registry existence. So I hope that Dr. Brahmana will able to manage it and make it better, and there are a chance to start Indonesia cancer using this system. And this is about the INASGO. You can just inasgo.org. And this is how we put the cancer registry. Just join the cancer registration, and there are 4 items that we share for the populations. The incidence, the stagings, the age, and the histopathology. So everybody can see. If you want to see the incidence of the gynecology cancer in Indonesia, you just click, and it will change by the time every data inputter will fill it in the cancer registration. And as you can see, the cervical cancer is still the highest rank. It's not in line with the maybe in Korean or in the Western people. And from the if you want to see 5 years about the incidence of cervical cancer, whether is there any difference, and we can see there is no other difference. It seems that we are not exist in Indonesia because the cervical cancer incidence is still high. And this is also the task for the government for preventable disease. We are still in these positions. And how about the stage? How about the stage? We can see that the stage is within 5 years, the stage of the cervical cancer are still 85% in advanced stage, stage 3B and 2B. Maybe you are amazed from Korean and Japanese group, how come that preventable disease are in the first rank and mostly come in the advanced stage? The answer is because the screening coverage is still low, of course. And you can make it fast. Dicepetin boleh nggak? Okay. This is personal for every center, so they have their own ID number. So I cannot see what Dr. Brahmana or Surabaya put in their cancer registry. So to make this is not only to move the patient's data from the big book to the cancer registry, but it has to be sound with the thing that we want to know. Mungkin boleh dicepetin. So we choose what kind of the cancer. Cervical cancer have their own items, ovarian cancer have their own items, and as you can see, if you choose a cervical cancer, you can see this from the figure stage, from the metastasis, from the imaging, for the histopathology, before the operations, after the operation, the number of the lymph node, LVSI, the treatment, starting when, finish when, the response, whether it's complete response, or progressive response, and also the follow-up, and also the dicepetin aja, yeah, the follow-up. Yes, last known the status of the evidence. And if we want to know whether how many cervical cancer stage 1B, the age is less than 40 years. In Jakarta or in Indonesia, you can go to the advanced search and just fill the blank that we have all the items. And let's say dicepetin mungkin bisa the treatment maybe operations or the cervical cancer stage 1B. The age is less than 40, let's say, so it will appear like this. So those kind of the patient, and we can move it to the SPSS. So it depends on you what you'd like to do with this data. Okay. And also we put it the survival, overall survival, disease-free survival, and progression-free survival. So overall survival, the date when the patients came and the patient died. Progression-free survival, patients came and treatment and progress, and for the recurrency, it has to be complete response and 6 months free from the disease. Ya, dicepetin aja ya. So this is a bit simple data from cancer registration diversity. Okay. As you can see, this is 28 teaching hospital in Indonesia, and you can see the activity of filling the cancer registry. And then we can also see the activities mostly from Jakarta, Surabaya, Bandung, And Dr. Brahmana, you have a heavy task to induce all the center to fill in the cancer registry. And the data can be obtained from UNESCO website. Okay. A simple evaluation, as you can see, the five year from 2010 and 2015 to 2016, 2020, there is no significant difference in incidence of the cervical cancer. So we have to do the evaluations of this for the government preventable disease and the incidence like this. And for the preventable disease, the state is still again the same, stage 3B. So against Dr. Brahmana, it seems that we are not exist in this society to reduce this preventable disease. So this is also need just simple, but I think it's a good data to give to the government to change about this situation for preventable disease. And this is the same. There's no significant difference cancer in the age group. Cervical cancer is still, old age is still found. And how about the screening? Still like in the screening. For endometrial cancer, it's a bit in line, actually in line with the international data, mostly came in the early stage. But nowadays we can see that now in the staging is in the 1B and stage 2. So we have to be careful because endometrial cancer mostly will come in the early stage because there is a symptom. So we miss to detect if mostly the patients came in the stage 2. And the age group in line with the international data, young adult is 6%, so international is approximately 4 and 6%. And mostly is endometrial cancer is endometrial adenocarcinoma in line, and for ovarian cancer, it's the second common gynecologic malignancy, so it's still the same in line with the international data. So we know that the young adults, so about 60%, maybe we should consider related to the hereditary gynecologic cancer, because this is something that we haven't touched it. When I give the presentation in Korea, I only be able to present, well, I don't have any data. So I just come and tell everybody that we don't have any data. So for research, list of publication from our cancer registrations, it's only local from Jakarta, maybe Bandung or Surabaya, but we never publish it, just made it and never follow it, and I'm gone. So this is a change of future research, maybe for the survival analysis, favorite gynecologic cancer, follow-up, evaluating intervention, multi-center research, such as example. This is something that we made, but we never do or follow this, like prognostic model of advanced cervical cancer after radiation in Indonesia, maybe, I don't know, or maybe the gynecology, sorry, the gynecological cancer statistic in Indonesia. See, Indonesia, maybe it will give something, because it will change every year. Multi-intentional cancer registry-based study. So the study is observational, consecutive sampling, cross-sectional, clinical statistic, and primary outcome with the prevalence, secondary outcome measure clinical pathology, treatment method, and prognostic. But just write it down, but nobody to execute this. Okay, I think that's all about our cancer registration. Actually, we do have a data, but we don't know how to use our own data for simple. I'm not saying that it's simple, yeah, but I think we should more use our own data. But if any, if someone said that, no, the cancer registry will give you nothing, of course, it won't give you nothing if you don't fill it. So I think it's our tax to fill it and our responsibility for our own data. Thank you, Professor Kim.
And thank you for your introduction of the cancer registry system operated on the INASCO web page. And in Korea, we have also cancer registry system operated by clinicians, but stopped several years ago due to various reasons. And we are going to restart the cancer registry system in Korea also, probably by Dr. Jong-yeol Park. So he will give us some comments. And the situation is almost same. And for example, in Japan, they just started the cancer registry system operated by clinicians. The cancer registry by the government is another aspect, and so we are almost in the same starting line. You are faster than us. So, Dr. Bach, please give us a comment, just one comment.
Thank you, Dr. Angi, for your introduction of your nation-based gynecological cancer registry. As Professor Kim told us, we had a cancer registry system in the past because of the law to prohibit the data using without patient consent. So recently, we are developing gynecological cancer registry. In this registry, we receive a patient consent, and we will use data gathering system and data management system, just like your system. And another hurdle in maintaining the database is the funding or money for run the data management. And the other problem is the validation of the data. Someone should validate the data continuously. These are the two big problems. And recently we have funding for registry and now developing the registry. And our future plan is merging each cancer registry in each country in Asian area. And we would like to have a big cancer registry, including most of the Asian country. So about this plan, there will be a cancer registry session in ASCO 2023 ASCO meeting in Taipei. And I have one question. Do you obtain the patient consent before registering the patient data in your system?
Yes, we give the informed consent to the patient because most of gynecology is government hospital and located in the teaching hospital. So they know that when they come in our institutions, there will be information that are going to be used for the medical purposes or scientific purposes. So we give the informed consent that we are going to use this data, but we are not going to use the name. There is no name, only the data, and we give all the informed consent that when they come to the hospital, they know that this is the data will be used for the, because all the government hospital or medical hospital, a teaching hospital, so they know that this data will be used, but without the name.
Okay, thank you for your discussion and talk, great talk. And yeah, please.
Or organized by government. So because the cancer registry that was presented by Dr. Anggi actually is not government cancer registry. This is not official from the government cancer registry. It's just a cancer registry created by our society. I'm wondering in Korea, its cancer registry is organized by the government or by your society? Thank you.
Yeah, we have a cancer registry operated by National Cancer Center, and at the cancer center we have a department dedicated to the registry, but the registry information is not, I would say, our interest is not reflected that system, so we need our own cancer registry system operated by ourselves, our society. So Dr. Box will start that new system.
Thank you very much. Thank you. Thanks.
Yeah, if you don't have any more questions or comments, I'm going to close this session. And thank you for your speakers and discussants and the audiences. Thank you so much.
Okay, let's give
Terima kasih.
round of applause.